There's all these possibilities, and it takes a lot of experience to build up that sort of educational caseload in your head to think about, like, oh my God, what is the worst possible thing this could be?
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, it's Kevin McFarland, and welcome back to the Art of Emergency Nursing podcast. Thanks for listening to the show. I really appreciate you. As always, getting a lot of great feedback on the Facebook and Instagram. If you're not following me there, please get on social media and follow us in those channels. And shout out to the podcast on one of those social media so that your friends see, because we want your friends to know that you listen to this podcast because you're cool like that. I have another great episode with my friend Dr.Wolf. I don't know what else to say. You guys know she's amazing. You've heard her on the podcast before. So I'm not going to give her much of an introduction. She's awesome. She's amazing. She is the one, the only Dr. Wolf. I wanted to talk to you a little bit today about the concept of thinking like a nurse. And this is 100% a selfish ask, because one of the things in my new role I need to do is we're working on doing a fellowship where we're going to get nurses and train them to be ER nurses. But I always think of the concept of,
I can help you.
how do we make nurses, students, nurses, people, how do we make people think like an ER nurse? Because I think we think a little bit differently.
Absolutely, and that's really the critical piece. And this is where, this is where my career started. I was basically given the task of orienting 4 or 5 nurses, 4 of whom had literally gotten off the plane from the Philippines like the day before. Were not emergency nurses at all. They were like med-surg and labor and delivery nurses. From the Philippines, brought to New York because we had a huge nursing shortage. This is back in like 2004. And they said, okay, so this is your job, basically, is turn them into emergency nurses. So I was like, okay. At the
easy
time,
peasy.
Right, easy peasy lemon squeezy. So I had been teaching for a couple of years at that point, on the college level, right? So I was trying to figure out, like, okay, how can I take what I know about teaching? And I was in a master's program for nursing education. So how can I take all these things that I know now, plus my 7 or 8 at the time years of nursing experience? Like, how am I going to do this? So I went around actually and talked to some of the really like oldest, crustiest, crabbiest emergency nurses in my department. And I said, okay, what is it about what we do here that is different from what they're doing over in med-surg? And, what do our nurses have to be really good at in order to do this? And so they gave me a list of soft, what you would think of like soft skills, right? So you have to be able to assess. You have to be able to identify acuity. You have to be able to anticipate the bad thing. Yeah. You have to be able to communicate your concerns in a way that someone who cannot see the patient can share your concern, right? So you have to be able to describe that patient. You need to be able to anticipate interventions. You need to be able to chart them appropriately and document them appropriately, because at this point, of course, we're all on paper. And then you need to evaluate what you've done and be able to communicate that back to your colleagues and providers, right? So here are these kind of really important soft skills. But what it really spoke to was this idea that the emergency department patient is essentially unknown and they are potentially acutely ill, right? So those are the 2 big things here. You don't really know anything about them. You have no charts, you have no records, you have a sketchy history that's given to you by someone who may or may not have any idea what's wrong with them. And you have to be able to kind of cut through all of that noise and zero in on what are the things that are going to kill my patient. Does this patient have any of those things? And if so, what do I do about it? Right? So that's kind of, I think, the process. We have to think backwards, right? So if you think of the way that you were taught in nursing school, right? Okay, class, today we're going to learn about pneumonia. Today we're going to learn about congestive heart failure. And so here's, what happens when people have congestive heart failure, and here's the medications that we give them, right? So all of that is really great if you know the patient has congestive heart failure. But emergency department patients don't present that way. They present with difficulty breathing, which can be congestive heart failure. It can also be a PE. It can be broken ribs. It can be a pneumo. It can be some kind of crazy abdominal thing that's pushing their diaphragm up, right? So we are dealing with symptomatic presentation, which has an enormous number of possibilities in terms of etiology. So how do we teach people to look at a symptom and be able to almost do a quick, almost subconscious, right? So by the time you're old like you and me, you can smell death across the room, because what we're doing is we're doing this subconscious review of systems every time we're looking at somebody, right?
True.
And
I always tell people, you do this in the grocery store. You're like, oh,
absolutely.
Look at that person walking down the road who can't breathe. I'm not going that way.
Right. I can't go to Disney because I want to bring a defibrillator, right? So this is the way that emergency nurses think. If you're good, right? There are still, we know people who've been nurses for 30 years who can't see acuity if it bit them, on the nose. But the really huge problem with new nurses is that they cannot perceive acuity. And so getting people to the level where you feel like somebody who's really sick is not going to get by them, it requires a lot of concentrated effort. And the way that I have done this, I kind of look at the way Benner has set up that model, right? So novice to expert.
Uh-huh.
So you've got your novice who doesn't know anything. Those are your students, those are your brand new nurses. They don't know anything. Within about a year, you can get them to the level of advanced beginners who are very good at task stuff, right? And having a sense of this arc is really, really important when you look at how emergency departments are currently staffed, right? Mm-hmm. So if you have your advanced beginner, you've got somebody who can kind of see what's in front of them, but they don't know necessarily how to go looking for things, right? So if you present them with a case study, they'll probably do okay. But if you say, what information do you need? They may or may not, they still need a lot of oversight.
Yeah.
Not precepting necessarily, but somebody keep, checking in on them, right? You don't want that person in charge.
Uh-huh.
Then within a year or two, you get them up to this competence phase, right? And that's really the point where you can be okay, I think that maybe you're at the point where you could convey what you know to somebody else, and that would be good, right? So you really don't want nurses with less than two or 3 years experience precepting other nurses, because it's just at this competent phase that they start seeing the bigger picture.
Mm-hmm.
What we really want to do, but then you get to this proficiency, this phase of proficiency, right? And the proficient nurse kind of sees the gestalt, right? Sees the bigger picture, is able to pick up on more subtle cues, that's sort of slightly off color. And the reason that they can do that is because they have enough experience that they have almost a library of cases in their head, right? Yeah. So you think about the cases where you're oh crap, I'm never going to miss that again. Yep. Right? If you ever seen flash pulmonary edema, or you've, smelled a really bad GI bleed, right? That sensory...
That sticks with you.
That sticks with you, right. Those are called paradigm cases. And what they can do is they're so rich and vivid that they can change the way that you think about patient presentations, right? So you think about the patient who walked in and you're oh, they're fine. And then they died. Yep. In front of you, and you're uh-oh, I'm never going to miss that again.
And you remember everything about those ones.
Every detail, right.
Every detail.
Exactly. So the question that we're trying, so without killing people, how do we help new nurses build that library of cases? And there's a couple of ways to do that. One is to have really intensive supervised clinical experiences where you can show them things without having to let them make any kind of like fatal mistakes, right? So that speaks to a fairly long, fairly intense orientation process.
Yeah, that's
which may or may not be possible, right?
Yeah.
The second way that you can do this is kind of like the condensed version is through simulation.
Okay.
Right?
Yeah.
So you can present, and what I used to do with my orientees and even my kind of snuck it in a little bit to my student experiences is I would give them a set of symptoms, like especially if we're talking about emergency department stuff, I would give them a set of symptoms that could be like an ESI 4 or an ESI 2, depending on the questions they asked, right? The information that they elicited. Like, so I had in my head 2 cases. One was a 4, one was a 2. Same thing, same initial presentation. And then I would kind of let them run through, and then you could kind of ask them, like, so what about this? Have you considered this? Did you ask about this? Right? And so the simulation itself becomes the paradigm case.
Okay.
And so this is definitely one way to do it. So looking at so let's take the case of a 19-year-old college student, right, who comes in vomiting. And you say to the student or the orientee, okay, so what do you need to know, right? You're in a college town. You've got a 19-year-old girl in front of you. She's vomiting her guts out. What are your differentials, right? And of course they're like, well, she's drunk. Well, that's possible.
Maybe.
Did you take a blood sugar?
Yeah. Well,
Her blood sugar's 512. Now what do you think it might be, right? So there's sort of these moments where you can walk them through the cognitive process, and what you're trying to avoid is premature closure, right? Deciding what something is before you have all the information.
mm-hmm.
And so this is where old nurses can be kind of terrible, because they're like, I've seen everything, I know what that is, but they don't. And to the simulation experience for triage especially, or emergency department stuff, I found that the most experienced nurses were actually the worst at it.
Huh.
Because they kind of figured
Too many options.
Either that or Occam's razor, right? When in doubt, they're drunk, right? We're in a college town. They've seen so many horses, they forget to look for the zebras.
Yeah.
And so I think it's really important to also have so nursing as a discipline, right, is not task oriented, right? We've talked about this before. This is an intellectual exercise, but it also has, it's intellectual, it's clinical, it's relational, and it's ethical, right? So all 4 of those things need to go into how we are orienting new nurses. There's the intellectual problem solving work. There's the application of that intellect to the unique clinical situation in front of you. There's the relational component where you actually have to talk to people. You have to extract information from them. You have to establish a relationship so that they will tell you things.
Yeah.
Because you don't have a chart to look at.
Yeah, I mean, how many times do you see someone, it's the first time, their first encounter with your healthcare system?
Exactly. And there's no record in the computer. They have a hard time remembering what meds they're on. Maybe they don't speak English well. You really need to establish a therapeutic relationship very quickly to get them to trust you, to give you that information. And then the last piece of it is the ethical piece, right? So every nursing decision is an ethical decision, in terms, especially at the assessment phase of the encounter, where you need to actually ask all the questions, and you need to follow the line of inquiry where it goes. even if that place is a place that your provider will shake his head at. Because why are you going to look for trouble? But that for me is really the ethical piece. It's doing what you need to do for the good of the patient, kind of regardless of what that means for other things or other people who might be mad at you. So to teach these new nurses, like, assessment is not just like the questions in the computer. You have to sort of take the symptom, figure out some differentials, and you need to pursue them to rule out the lethal ones.
Yeah.
So
if you can rule out if you rule out the lethal ones, then you have more time to explore further.
Exactly, right? So if you've got somebody who's got chest pain, even if they're 25, even if they, don't appear to be in what you would consider to be a classic state of distress, you still need to do the EKG.
Yeah, absolutely.
You still need to ask all the questions, how about pain, about history, because your 25-year-old might have Marfan's and has right now a dissecting aneurysm in front of you.
Yep.
There's all these possibilities, and it takes a lot of experience to build up that sort of educational caseload in your head to think about, like, oh my God, what is the worst possible thing this could be?
I remember once a doctor saying, it was a resident, and I remember once him saying, that a lot of emergency medicine is simply pattern recognition. Like looking at the thing and saying, okay, I've seen this before. What did it look like? What was it? And then applying that to that mental Rolodex of patient encounters, and then applying that to the next person. Absolutely.
But there's this philosopher that I encountered in graduate school, Bernard Lonergan, and he wrote a paper called Insight. So it's really sort of a way that you collect information, you make a judgment, right? Now, if you're really good at your job, you ask the next question that will confirm or challenge that judgment. If you really suck at your job, you will make a judgment and that's it, right? So let's take the case of, you have a 60-year-old woman who shows up in January in your emergency department, and she's kind of pale, and she's like, I'm so nauseated. Everybody in my house has the flu. I'm sure I just need some Tamiflu. I started feeling terrible this morning, and here I am, right? So if you suck at your job, you'll be like, oh, okay, well, it's flu season, and everybody in her house has the flu, so, I guess you have the flu.
Yeah.
Right. But then if you take a set of vital signs and you find that the patient's temperature is 97 degrees,
you're like,
what do you think?
Maybe not.
Well, do you go, or do you say, oh, maybe not the flu, or, oh, I'm sure she took some Tylenol before she came over here.
Yeah.
Right?
I
do you
see it
actually
being really
recognize...
easy to do either. It's easy to do either. But if you
totally is.
If you err on the side of caution, then you're like, well, maybe this doesn't fit the clinical information that she's laid out for us. Right.
So what do I need to rule out in a 60-year-old woman who feels nauseated and weak?
Yeah.
Maybe I should do an EKG. Maybe I should look at this as a cardiac equivalent. Maybe I should think this is an absolutely classic presentation for a female having an MI.
Yeah, absolutely.
Right? So again, this is especially like in triage, right? This is where I really think that you should not, ever feel comfortable in triage, right? You shouldn't ever be in a groove. I hate when people say that. Oh, I'm in a groove in triage. No, you should be terrified every single moment you're in triage. But people really shouldn't be in triage for more than 4 hours at a stretch, because otherwise everything looks the same, right? Everybody has the flu, or everybody has a stomach ache, or everybody's got the stomach ache, right? And so you get you almost get skewed toward that less acute problem than you do toward really looking at each individual and figuring out, like, okay, so they're telling me what's going on. What do I see? Does what I see align with what they're telling me? And am I coming to, like, the logical conclusion, or is something wrong, right? Like, this vital sign does not fit into that picture. And what people tend to do is they tend to ignore that or explain it away, right? So
It's easy to do.
This is why of course it's easy to do, but this is why we have such a huge problem moving the needle on sepsis, right? Because you're like, oh, well, their, heart rate's 95 and they're breathing a little fast, but you know what? Like, they're nervous.
Yeah.
Rather than picking up, these things early enough to do stuff, right? So, yeah. I always teach my students that, like, we are the firewall between patients and death, and so you have to take that job.
Not dramatic at all.
No, but
but
sometimes
true.
you gotta really line it up. Like, hey, here are the stakes.
Yeah.
This is not about, like, I don't know sometimes why people go into emergency nursing, right? I'm like, the whole point of this is that you're a detective. Like, that's the fun part. The task part is not the fun part.
Yeah, for sure.
Right? Like, I was working in the ER yesterday, and I had I was floating. So I had 4 or 5 real emergencies, like really critical patients. It was great. I was like, oh, what's going on? Let me figure this out. Do stuff. It's great. Like, this doesn't make sense.
It's a special kind of weird that really enjoys being in the emergency department. That's for sure.
Absolutely. But to get people up to the point where they're not just running around trying to, like, hang antibiotics in time, right? So that's sort of helping people through that rough patch where they're still kind of fumbling around in the dark, by holding out this big yummy cookie of, if you study hard and fly right, you too will be a great detective.
Yeah. And it's hard sometimes because it's easy to get caught up in the taskiness of emergency nursing.
Oh, sure. Because you don't know them, right? Like, you don't really have a relationship with them. So, like, you're just kind of doing things to them, around them, whatever. And I think that's also how people kind of get burnt out, because they don't really see their patients as people. And I think right now in my career, I am lucky enough to work little enough, right? I work 2 4-hour shifts a week, to really go in there and connect with people, because I know I'm only there for 4 hours.
It's easy. It's easy when you're doing those little princess shifts. You come in, you're like, I'll do whatever you want me to do for the next 4 hours.
Exactly, sure. And I can be nice to people, and I can find things out, which makes me, as a float nurse, really useful. Yeah. In the department, right? Because I can go around and kind of ask a few more questions, and then be able to go to the nurse and be like, so I noticed this, were you aware of this, or this seems to be changing? And they could be like, and then they're on it, right? But they don't have the bandwidth to really see that unless they've got a lot of experience. Like, the experienced nurses can do that, no problem. But it's those nurses who are still in that kind of new phase where all they can focus on is, like, the thing in front of them.
Yeah. Yeah, that it's hard to sometimes get past that.
Yeah, it really is.
Especially in the environment that we put people in some emergency departments where, we're like, you come in and you feel like you got your ass kicked for 12 hours.
Exactly. And this is where the staffing mix is so important, because if you've got a whole bunch of nurses with 1.5 years experience on, that's their weekend with no more experience than that, they will never learn how to do it, because you've got to show people You've got to have more experienced nurses who can talk them through the process, right? And this is where I think if you've got a really young staff, like a less experienced staff, getting a more experienced nurse or an educator, right? Either or, on the floor with them for at least a chunk of their shift, to help them process, to pull them away for a second and say, okay, what do we think about this, right? So your patient has, is here with, they have end-stage renal disease and their heart rate is 40. Why do you think that's happening?
Yeah.
What do we need to do about that? I know it was that when they came in, but why do you think that's happening?
Yeah.
What do we need to talk about? And I think I've talked to you about this before, but like my favorite job ever was as a night educator, just walking around and talking to people about their patients and, how to really take vital signs accurately and what they mean. Like, how do you make meaning of what you're seeing? And I think that's really the critical piece when we talk about recognizing acuity and stuff like that, is how do you take a set of vital signs and put it together with a patient presentation or a set of labs and put it together with a patient presentation, and those things paint a picture for you that can point you in the direction of like, this is a really serious situation, or, oh, this is more reassuring.
Yeah. And I don't think everybody, like, I know experienced nurses that have a hard time putting all those things together. Like, look at the vital signs, look at the patient history, talk to your patient, get a little more information, look at their labs, look at their labs. It's like all the pieces are there, and but oftentimes I think there's a lot of nurses that just get kind of focused on, no, it's not my, I'm not going to diagnose them. I'm not going to be the one to figure this out. Of course you are.
Sure you are. That's the fun part. But also, like, especially if you're the first person, I mean, in a nurse-driven environment, you have to have nurses who can diagnose, or at least come up with a list of possibilities, because that tells you how sick the patient is.
Yep. Yeah, you're right.
Right? I mean, that's the first thing you do. You don't go in, you don't see a patient with like flank pain and say, gee, I have no idea what that could be. I'm going to treat his pain, right? You think, oh, that's a renal colic.
Yep, exactly.
Or a dissecting renal aneurysm. I'm not sure yet. I have to do a CAT scan.
One or the other.
Right? Like that, and that's why we do a CAT scan. But the number of people when I said that in an orientation class to so like some preceptors were sitting in and they were like, oh, I didn't know that's why we did the CAT scan. I'm like, oh my God.
Like,
yes,
oh, yeah.
To rule out the other bad thing, right? Because kidney stones won't kill you. They're very, very painful, but they're not probably going to kill you.
Not going to kill you. You just feel like you want to die.
Exactly. No kidding. So I think the whole way of thinking like an emergency nurse, like there's all of those things, right? That intellectual and clinical piece, and really establishing a relationship with people that can be difficult, right? Because they're not at their best. They're in the ER. And I think really thinking about what is best for this patient right now is that ethical piece. And we have to have in working environments in which all of those things are supported and taught. What drives me crazy is that I would just orient the hell out of some nurses for weeks. Like I'd have them for 16 weeks and I'm like, they're going to be awesome, and 6 weeks later I'm cruising through the ER and I say, okay, what's up with your patient? I'm like, oh, well, he's a 25-year-old guy who's complaining of some chest pain. I'm like, why is he not on a monitor? Why does he not have an IV? Oh, well, the doctor said it was fine. I'm like, why? Like, did we not have this conversation for 16 weeks? Every patient is, with chest pain is a 2 until proven otherwise.
Yeah.
And they would just get ruined in the environment because it's the culture of, not so bad.
Yeah.
Right? Nobody wants to be seen as hysterical or overly concerned, right? Because that's what we are as ER nurses. Like, we're cool with everything. Like, oh yeah, that doesn't look so good, right? But the nurses, the older nurses, the more experienced nurses who are sitting there kind of like raising an eyebrow, going, that doesn't look good. They're also in the process of, as they say that, of putting the patient on the monitor and throwing an IV in and knowing what they're looking for. They're not actually dismissing it.
I remember I had a patient who came in and she had, a good story for stroke. And I was like, I think this is complete bullshit. As I'm, hooking her up to the monitor and getting everything all set to go, ordered a CAT scan and, take the chart, put the chart in the rack, and, the doctor goes, hey, what's going on with that patient? I go, well, they got a good story for a stroke. I think they're full of shit, but they're going to go to CAT scan first. He's like, oh, okay. So sure enough, it comes back, oh, way to go, Dr. Kevin. She's got a huge bleed. And I'm like, well, that's why I sent her to the CAT scan. So to find that out.
Because it doesn't matter what I think.
It doesn't matter what I think. I'm going to send her to the CAT scan anyway. We're going to trust, but we're going to verify.
Right, exactly. Like, I don't think this is anything, but you know what? If I miss it, that's a big problem.
That's bad.
Right,
yeah.
That would be super bad.
Yeah.
Right, absolutely. Like, this guy came in yesterday, and he just looked terrible. And I'm like, holy crap, that guy looks terrible. And this was somebody else's patient. I was kind of walking by, and so I turned to the nurse, and I'm like, what's up with that guy? She goes, oh, well, his blood sugar is like 515. And I was like, yeah, that's about right. And I'm eyeballing. I'm like, yep, okay, he's got a couple of liters going, and he's on the monitor, and we're getting an ICU bed for him and stuff. So
yeah. I remember as a house supervisor walking by rooms, going, okay, that guy needs a bed. How soon? And they're like, not that soon. And they're like, he just got here, and I'm like, yeah, and he's gonna get admitted. So let me start. Revising my plan. Let me just
start looking. Right, exactly.
Let me revise my plan because I can see that he's going. I don't know anything about him, but I can see that he is not well. So
right. And even that, like, I still tell my students, like, go get a grown up. Right. You don't have to know 100%. Like, you don't have to be able to articulate 100% that something is very wrong. You need to be able to go get somebody who knows. And who can walk through that assessment process with you so you can learn it, right? When the rapid response team comes to the room, that's not your cue to walk out. That's your cue to stay there and ask questions, and watch those nurses do their assessment and ask them what they're looking for, right? I think it's, I don't know. I think especially with this sort of rash of second bachelor programs, you've got a bunch of people who are really used to being smart, right? And learning nursing, especially emergency nursing, is very, very humbling. And the ability to just kind of really maintain an open mind and ask a lot of questions, and not be totally worried about whether you look stupid or not. Like, I ask tons of questions. I tell my students, I look up meds all the time, because my patient's safety is more important than me looking smart, because I look really stupid if my patient craps out because I didn't ask the right question,
right?
Or I didn't look up the med.
Yeah, that's a good point. That's a good point. Sometimes I see nurses give meds. Like, have you ever given that med before? Like, nope. Gonna go ahead and give it though. And I'm like, well, let's just look that up for a second.
Let's look it up. Right. Exactly. Like I'm really good with remembering like mechanism of action and all that stuff. But like, I still got to look up what do I dilute this in?
Yeah.
How fast do I push it? Just assuming it drives me nuts when you're like, hey, so how fast are you pushing it? Slow. What does that mean? Does that mean 2 minutes? Does that mean 5 minutes? What does that mean?
Yeah, how slow?
And if you're pushing it over 5 minutes, why do you have it in like a 3 cc syringe? Like, put that sucker in a 50 cc bag or something.
Right. That'll get it in over 5 minutes.
Right. So kind of crazy.
So now I can say that I'm lucky enough to work in a system where we have educators, we have great educators, For the systems that aren't as lucky, you're precepting a new student, you're precepting maybe a second bachelor student or a brand new student to the ED. Where do you start with those guys? You're not the educator, you're not the primary educator. You are just happen to be the one who gets to be with this person for the next 12 weeks.
Right. It's your day. You start, I think, with the very, very basic things, right? In terms of assessment. You start with this idea that you're looking pretty much at a blank slate, right? Like nobody's going to, any information that you get, you are going to have to pull out of that situation and out of that patient. So here are the important questions you need to ask a patient, right? Why, if you start with, even if it's your first encounter, right, they've already been triaged. So you have sort of a basic idea of what the presenting complaint is. Let's say abdominal pain, right? So you've got a 30-year-old woman with abdominal pain. Okay, you go in, you introduce yourself, and you start asking questions while you are putting that patient, up to the monitor and the pulse ox. Like you're getting a set of vital signs. You're getting kind of a gestalt look at them and start asking questions. So when did this start? How long have you had it? What kind of pain is it? Where is it? What makes it better? What may do a really good pain assessment. Ask, like, what are the obvious causes of abdominal pain in a 30-year-old, right? Do you have your appendix? Are you pregnant? Have you ever had ovarian cysts? Kind of going through the list of potentially bad things. And then you look, after you've talked to the patient and you've established a rapport, now physically examine their abdomen. Is it tender? Is it distended? What's that focused assessment? Like, especially with an abdominal assessment, what are you actually looking for? You're listening for bowel sounds, you're feeling for tenderness, you're feeling for tightness or tenseness, you're asking about, OBGYN stuff, you're asking about GI stuff, you're asking about GU stuff. Does it hurt when you pee, right? To kind of work your way through the list of potential things. And then if your patient's vital signs are okay and they don't seem to be in a huge amount of distress, then, send off your diagnostics and kind of sit back and see what comes back, run a bunch of stuff up the flagpole and see what comes back. I remember back in the day, we used to, we were a completely nurse-driven emergency department, which was awesome. And so somebody would come in with a complaint and we'd put them in for all the labs and all the diagnostics. Like I remember handing people contrast literally in triage. Here, drink this. It's going to take an hour and a half for it to filter through. And, we want to just speed things along. You can't really do that anymore.
Yeah.
But we certainly had a really good sense of what was going to be done to confirm a diagnosis. I think somehow that's kind of been lost in a way because there are a lot of departments that don't have the same kind of nursing culture that I certainly learned nursing in, which was, we have one doctor, we have 30 beds. It's 3 a.m. You got to do a lot of the legwork.
Yeah. Yeah. I think, I think that's often the case is, especially in like smaller EDs where you're like, I have one doc and he's not going to see this person unless I grab him. He's not going to see this person for a little while.
Right. And how do I justify grabbing him away from that other patient? Well, I need to have some information, right? But part of that culture is that the physicians and the nurses trust each other enough that, the doctors are like, oh yeah, if you ordered it, that's fine. Okay, yeah, I know how you think. We think along similar clinical pathways, and so this makes sense to me. And, certainly I'd run it by them. Like, hey, if I was going to do something weird, right? Like, I'm going to order this test. Are you okay with that? And they're like, oh yeah, sure. Or wait, let's get this thing back first, right? But so there was conversation, but there was a lot more reliance on the nurse's expertise.
Exactly.
Again, in ways that are I don't see as common now.
Yeah. Yeah. It seems to be less and less of that.
Right. Well, we've kind of gone from like the narrative to the checkbox, and like the whole thing is getting a little more automated, and it feels kind of dumbed down a little bit to me. Not in only because it doesn't give nurses the opportunity to really latch on to that thought process. Like, why do we have an abdominal panel? What are the things that we're looking for? Why would you order liver labs, as opposed to not, right? What are the things that would cue you to, what pain location or other symptoms or physical appearance? Like, why would you think like, maybe there's some liver involvement here? Maybe this is pancreatitis or, how do you make those decisions?
Yeah.
Yeah. So a lot of I think the sort of training and acculturation of emergency nurses needs to take place in an environment where nurses are talking to each other about patients, right? So, another thing that's a little bit different is that, I think people are generally working mostly like on the short staff side, right? So everybody's just very focused on getting through their shift with their patient assignment. And so the amount of space available to kind of talk about patients is certainly less, like this is why I think like night shift is actually the best place to train, because there are generally like those little spaces where nurses can talk to each other about patients or ask questions or to sit around and kind of shoot the shit with the docs about, a patient. And I think that unless you've got an environment in which that's possible at least some of the time, you miss this huge opportunity.
Absolutely.
To pass on a lot of knowledge.
I think one of the things that, one of the things I find in a busy emergency department when you're just so busy, just, making sure everybody lives through your
Nobody
shift.
dies, right?
Yeah, everyone lives through your shift. Nobody dies. But you miss those opportunities to have those, kind of case studies and talk about stuff. And I think
right.
that's the case not only for nursing, but for medicine as well. I mean,
absolutely.
A lot of times you'll just see an attending physician just be like, just give me the laryngoscope and scoot over. So,
right.
You're like, just give me the airway stuff and I'll take care of this. So,
right.
But, and it's one of the, they're missing a great opportunity to say, hey, we could make this a great learning experience. And not always is that appropriate, but if it is appropriate, great.
Yeah. Yeah, because that's, having taught like in the very early part of my career, as I was developing this, idea of how to teach to proficiency, essentially.
Yeah.
I was in a level 1 trauma teaching hospital, but it was like the county hospital in New York. And so it was just it's where all the residents trained. There were some questionable practices. It was very focused on just getting stuff done. And so I was able to have my students like really see those paradigm cases, to really talk to the nurses that they were paired with, and the physicians as well. There was a lot. I mean, it was a real teaching hospital. Like everybody really, that was the goal. Everybody learned from everybody. I had my students go on rounds with the medical residents, just to hear, like, this is how doctors learn.
Yeah.
And nurses can learn this way too. Like, we can stand around a patient's bed and we can talk if the patient, can't hear us. But what nurses do is we look at the patient, we look at all the stuff, and then we go into another room and we talk about the patient. But yeah, I mean, that was a fantastic teaching opportunity. I really love that.
I bet that seems like that would be a great place to be able to have, give them a chance to see some of those lessons and think clinically, think out, think things through. which I don't think they always get a chance to.
Right, and I don't really think that because nursing school is so compressed now, I don't know that it is standard that nursing students get that kind of questioning either, right? Like, this is why, students hate me when they have me. They love me 4 years later. That's when I start getting the notes like, I'm really sorry for what I wrote about you on my evaluation. But to know, like, to hold people accountable for their knowledge, right? Like, you actually have to have a sense of what's wrong with somebody. You have to, and if you don't know, you need to go look it up.
Yeah.
If you can book a table at your favorite restaurant on your phone, you can also look up what you want to do for a patient in congestive heart failure. You know?
What are your favorite resources to give students who are or give new to the ER folks? What are some of your favorite resources to suggest to help them kind of learn as much as they can on their own?
Right. So when I was in nursing school, my classmates and I, this is how old I am, we used to watch ER.
Oh God.
on Thursday nights, seriously. And that was like our homework. We would try to diagnose before anybody else did. Like, oh yeah, that's it. You can't really do that now. But I really
didn't work well with Grey's Anatomy. I think they,
right.
You're never going to see this.
Right. Doctors do not draw blood. I take a really pathophysiological approach also, right? Sort of, where is it? What does it do? What happens if it doesn't work? How do you fix it? And so for nurses who have not had formal pathophys classes, they really need that understanding of like, what are the possible pathophysiologic reasons that the patient is short of breath? Like, how do you tell congestive heart failure from pneumonia, from an abdominal issue, right? So I refer them to, like, Khan Academy has great videos on things like, the things that are really hard to explain, like fluid and electrolytes or acid-base balance, or they have, I think, a lot more resources now for medical and nursing students.
Really?
So I think, yeah. So
idea.
That's really good. Yeah. So that's really handy. I also love YouTube, and I use it to teach my med-surg students also. Like, I'll show videos of things like, so you can, have a student read in a textbook about what somebody who's tripoding looks like, right? And you get the terrible picture in the book. But if you show them a video, like, that's another way to kind of build that library of cases, right? Like, This is a kid, this is what retractions look like in a kid, right? This is what it looks like when somebody has aspiration pneumonia. So video, I think, is really important. There's this scene in, I think the movie is Three Kings, where they show a
pneumothorax.
A pneumothorax and a decompression.
Yep.
And so I show that in my class so they can see what that looks like.
I got that.
Because it's fantastic.
So we had, I think I showed that video to every one of my EMT classes. Like, every single EMT class got to see that video. And we kind of narrated it and said, here's what's happening. Here's what we're seeing. Here's what you're going to hear.
Exactly.
And we had like this little narration crawl at the bottom. I'm going to have to find it and send it to you. Because it was just kind of cool. Like, it was like one of our favorite videos to use to teach.
Sure, absolutely.
I have a whole handful of videos that, like, I always showed, and then I was like, they used to always joke. My students would always joke and be like, "Hey, we heard that when we talk about peds, we're going to get to see the dying baby video," and I'm like, "There is a dying baby video," and it was this old respiratory distress video from like the 50s where you're like watching this kid going, "Somebody intubate."
Right.
But it was one of those, like, how powerful to see, retractions, how powerful to see gasping agonal respirations. So,
right.
But this
because you're not going to forget that.
You're not going to
write that off.
Nope, you're never going to forget that.
Exactly. So, I think I think it takes some work to find appropriate, useful video, but it's out there certainly. That's really like I spend a lot of time when I'm teaching or doing an orientation program, like looking for that kind of stuff, like that aha moment stuff.
Yep.
Especially for the kind of low volume, high stakes kind of stuff. Like you may not see this in real life. Like I remember being a student and taking one of my classmates, like took report on a patient, went to see him, went back to get something, and when she came back, he was in flash pulmonary edema.
Huh.
And like couldn't breathe, was breathing at like 50 or 60, clammy, pale, lungs sounded like the bottom of the ocean. And we all, like, as they were, and my instructors were like, listen, take your stethoscopes and listen, as they're kind of setting up for a whole bunch of other things and they're positioning the patient or whatever, like put your stuff on his chest and listen. And I'm like, oh, yep, look at that. That does sound like the bottom of the ocean.
Yep, absolutely.
So the idea that, the patient who has something unusual can be a learning experience, like, oh, this patient has a gallop, right? How often, if you're not in a cardiology residency, how often do you appreciate a gallop? Not often. So get everybody in the room. Like, do you mind if we listen? Do you mind? Right? That's what it sounds like. Fix that in your mind.
Yep, absolutely. I remember we had a black widow. We had a black widow bite in the emergency department, and we were given the antivenom, and we had that going on at the same time we had a mass casualty, and everyone was like, yeah. There are students who are like, oh, I want to go see the mass casualty. I'm like, oh, you go ahead. I've never given antivenom, so I want to do that. Like, right. You guys can have the trauma, but I want to go do this thing that I've never done before. And I've never done it. Have you ever seen a black widow bite? No, me either. Come on, it's going to be fun. And
right.
Like,
let's go take a look.
One or two of the students are like, that sounds like that might be kind of unique. And I'm like, yeah, I don't know when you're going to see this again. So
right, like we scrape people up off the sidewalk all the time,
all day long. Yeah, you're just starting your 12-hour shift. You're gonna see that like five more times.
Right. Yeah, but stuff like that, snake bites, and even crazy stuff like measles.
Yeah.
Have you seen a live case of measles in your career?
I have not.
Well, you will soon, since no one's vaccinating their children anymore. But yeah, like, do you even recognize measles?
Yeah,
do people even recognize chickenpox anymore? Do they know what pertussis sounds like? In the environment where rates of vaccination are kind of dipping to really dangerous levels, we're going to see a lot more of this. And you got to be able to kind of spot that across the room. Be like, isolate these people right now.
Yeah. I remember taking the CPAN, and so much of it was, you see this in the waiting room, what do you do? And you're like, get them out of the waiting room.
Right. Exactly. So, isolate.
That's right. So.
Yeah, I gave a talk on infectious disease, like, I don't know, 4 or 5 years ago, and had to really look for good pictures of Koplik spots.
Yeah, it's not,
not really good.
Not easy to see every day. So.
Right. So there's all that kind of stuff that you really need to be open to that possibility, and there's so many reasons why people don't see what's in front of them, especially in the emergency department, right? Because nobody, you go through this period where everybody's dying, but then very quickly you get to the point where, like, everybody's fine. Why did they just stay home or go to their own doctor or whatever, right? And depending on the environment in which you're working, like, one of those two directions is going to be more supported, right? So if you're in the situation where, the whole goal is get them out of the waiting room, and nobody really cares where they go,
yeah,
or get them out of the ER. that's a very different environment in which sort of the unique situation is appreciated, both patient and environment. And that those are two very different work environments, and the learning process is very different in those environments.
Yeah. What other advice do you have for preceptors?
Oh, good grief. I think it's really important to be able to explain exactly why you're doing what you're doing. And if you can't, you need to go back and look it all up again. I think the worst thing a preceptor can do is to say to an orientee or a student, well, this is the way I do it. This is the way I learned to do it, without being able to say, this is why I'm doing this. This is what the evidence suggests that we do, and this is why it's being done this way. That's part of the reason that I love to teach. When I was teaching clinically, I loved to teach fundamentals, because I was like, I have to go back and relearn all of this so that I can explain it to my students. And it made me understand why I was doing what I was doing so much better. So if you're going to precept and you've been just doing what you do for a long time, consider like revisiting your fundamentals textbook. just kind of looking back at rationales for things. So that you can do that. Because if you just tell somebody to do something, then they never learn why or how or when, more importantly, when not to do it.
Yeah.
That's the key thing, right? You have to know when that's a bad idea, when that order is really a bad idea. I would also suggest that preceptors really kind of focus on asking process questions rather than like, did you do X, Y, and Z? But what did you see in that room? What do you think is going on with the patient? How do you want to proceed with their care? Because
encourage the thinking, encourage the processing.
Thinking. Right. Rather than sort of the task aspect, because that gets done, right? Like, because everybody feels competent when they can start an IV or program a pump or whatever.
It's so easy to get focused in on the tasks.
Absolutely.
I forget who it was. One of the guests I had on recently said, and it may have been you. Task nursing kills patients.
Mm-hmm.
And
yeah, that sounds like me.
could have been. But it's one of those things like, yeah, you're absolutely right. I mean, if you're just doing things because that's the way you do them,
right?
That's not
or
helping
even like
anyone.
I remember being an IV nurse at one point. Like I would per diem as the IV nurse, and I would go into, I would get this hysterical phone call at 9:45 at night, because all the 10 o'clock antibiotics had to be given. I have to get this IV started. I've tried twice. I can't do it or whatever. And I go in, I'm like, how long has this patient been dead? Like literally there was one where I was like, how long has this patient been breathing at like 4? And then like they didn't even notice. They were so focused on getting the IV. And I'm like, I have no blood pressure. No wonder you can't get an IV.
Right.
I was a little more, active than that, but
yeah, not much.
But you can, but not much. You can get like super focused and on the thing and forget about the patient.
It's easy to do. Yeah, for sure.
It is. So. And I think that's really the key piece in really teaching nurses, which is that you have to focus on the patient. Like the whole point you're here is because there's a patient there, not a task.
Yep, exactly. So. What else do I need?
A lot of stuff.
It's a lot of stuff. Holy cow. This is good information and it's given me so many thoughts. Again, like I said, this is completely selfish that we're having this conversation now. But I think it'll be a great podcast episode because this is the kind of stuff that people need to think about when they're precepting,
Right.
and think about when they're, a brand new nurse, or think about when they're taking care of those brand new nurses.
Right. If you teach them how to think, they can fly. If you just kind of teach them time management, then you just kind of crush all that. Like, nursing requires a certain amount of creativity.
Yeah.
Like, you have to be able to really look at a situation and kind of look into the future, right? And if you're focused on your 10 o'clock med, you're not looking into the future. You're looking at your 10 o'clock med.
Yeah, it's a good point. I never really thought of it that way, but it's a good point.
Yeah.
Huh. Gosh, this is exciting. Good stuff. Good stuff
Cool.
here. Yeah.
Good. I'm going down to talk. This may be interesting for you for selfish reasons. I'm going in like 2 or 3 weeks to go meet up with Kathy Lassiter, who's a friend of mine, who is the author of the Lassiter Clinical Judgment Rubric.
Huh.
And this seems to me the optimal outcomes measure for an orientation program. So, take this or not for your podcast, but basically the outcome of an orientation program has to be clinical judgment.
Yeah, I mean,
right? It has to be those soft skills. But think of how we decide when somebody's ready to come off orientation, right? Can they start an IV? Can they put in a Foley? Do they know how to chart? Have they been through the computer training? Did they sit in these classes? But we're not really evaluating their ability to make good clinical decisions.
Is it week 12?
Right, exactly. Do you think they're going to be okay? Right? And I think using this clinical judgment rubric is actually a really a much better objective way to measure readiness to come off orientation. With safety, because if you've got sort of a non-progressing orientee, and I think I sent you this article, those 90 days or that orientation period is the last chance you're going to have to get rid of somebody who's inappropriate for your department.
Yeah, I mean, the hardest.
It is really hard to fire somebody. And so to really make sure that somebody's safe or is progressing, trending in a way that is reassuring, I think is very, very important. It doesn't matter whether you quote unquote like them or not.
Yeah.
And what you're looking at more of is like, can they notice, appreciate, intervene, and evaluate around patient problems.
Yeah. I mean, that's really the goal. And we don't state it as such, but maybe we should. I mean, maybe that you're right. Maybe
I think we really should. Like if you can't do this work, you shouldn't be here.
Yeah. I mean,
that's
really,
and I don't care how good a
to.
Spanish major you were, right? Like if you can't be safe in an ER, you can't work in an ER. And I think we're very reluctant to say that. I mean, partly because, I guess we figure like a body is better than no body, and that's not always true.
Yeah, no, I think that sometimes that's the dangerous thing. And it's one of those that not everybody gets to be an astronaut, not everybody gets to be a nurse.
Right, exactly.
It's just they can't all, they're not necessarily all going to be able to do it.
Right, because it's such a nurse-driven environment, right? Like, so somebody who would do perfectly fine, like I've had students who've been, orientees who've been A students in their nursing programs who are terrible in the ER, because what they are really comfortable with is, here is the diagnosis, here is the order set, please carry out these orders.
Oh, that's easy. I can teach a monkey to do that.
Sure, but they're very good at it, and they're very comfortable with it, and they're lovely people. But if you say, well, you've got to figure this out on your own first, and choose interventions, they kind of fall apart. And those people may be good nurses in other areas, but they're not suitable for the ER.
Interesting. Yeah, I mean, you're right. That's one that you definitely, I mean, someone like that you definitely can't have in the ER because there's too many unknowns.
Right.
You know, if you're going to be in a clinic
and yet,
where you're,
there they are, you know?
yeah, you're right. You're absolutely right. Well, that's interesting. What do you guys, are you guys just, is this like an academic thing that you're working on, or is this like a ENA thing, or is this just for fun?
Well, I'm gonna meet up with her because she's an awesome human, and we're gonna have lunch. But my main sort of goal is to, I want to use this. I have this as the outcomes measure in our orientation program that we're working on, right? And that's really the pull, right? Is that when if you're using that as your outcomes measure, then you have to work backwards and devise content that really supports clinical judgment and is not just like, here's how you give blood and here's the sign off and here's the hospital orientation stuff.
I mean, I think
and we'll have you follow somebody around for 6 weeks and you're good.
Yeah, I think there's a place for that stuff, but it's a small place.
Right, it's a task.
It's a task.
Here's how you do this task.
We got to teach you to do that, but more importantly is we got to teach you to think to yourself, hey, this would be a good time to use that task.
Right, exactly.
That cool skill I just learned, this would be a great time to use it. So,
yep, indeed. Or hey, not such a great time. It's very cool, but this is not the situation.
Well, I can't thank you enough for, again, spending time with me and talking to me, and this has been fantastic.
Sure, it's really fun.
As always.
Yeah.
That's cool. And if there's anything I can do for you, please, please, please let me know. Because, gosh, I love
that you're sort of propagating my world plans for world domination. This is awesome.
Oh, this is gonna be easy. I mean, hell, again, we're going to be talking, maybe next month about PTSD?
Absolutely.
Yeah?
Yeah.
It's going to become, you're going to become like a regular on the
I'm like the regular
podcast.
I want my own coffee mug.
How cool would that be?
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.